Mike, and thank you very much, Derek. We move back to the upper abdomen. I'd like to talk about not one paper but two papers describing a total of 8 patients. I think if you sent Derek or Mike two papers with 4 patients each, you probably would be accused of trying to get a double publication in the same issue. It's written by Rodney Smith, who was a bit of a hero for me in my days as a postgraduate student. I never understood the mucosal technique that he describes in the second paper. To briefly summarize the 2 papers is what I'll start off with. Derek's also asked me to put this into perspective with where we are now, because a lot has moved on in biliary surgery over the last 40, 50 years with the advent of transplantation and laparoscopic cholecystectomy. Both these papers were designed to deal with the difficult post-traumatic stricture after open cholecystectomy. Okay? Open cholecystectomy has gone, but obviously the difficult stricture remains, and we'll talk a bit about that. So the first paper is a short paper looking at 4 cases, and he starts off right away with the principles of the procedure, that you have to do a mucosa to mucosa approximation, because what you don't want to anastomose is scar tissue to the bowel. It's important not to get tension, and it's important to get as large an anastomosis as possible. There's no further detail in terms of what is large and what is not large. What's very interesting is that this, as well as the next paper, describes a very short roux loop, a 20 centimeter roux loop. And again, they were quite innovative here in that they prepare this loop, try to dissect out as much of the common bile duct as possible, tunnel it through a good distance of the jejunum, and using this ring retractor to push the mucosal folds away, they would then do an intraluminal anastomosis of the biliary tree to the roux loop, close that off, and to achieve a tension-free anastomosis, put in tagging stitches. All of this obviously with catgut. So a total of only 4 patients with a very modest follow-up period for patients with biliary strictures. This is Act 1, Scene 2, the second paper following immediately on. And again, this is a much longer paper. This goes into 8 or 10 pages. It's a bit more descriptive. It's a lot more philosophical as well, in that they already start off before describing the technique about the different techniques that are available, and also says that it's very clear right at the beginning. He says that an injury must not be allowed to occur. So prevention is the key. So that's one thing that hasn't changed over that time period. And I think this is probably the first settings of specialist HPB surgery in terms of repair. That the first attempt at repair is your best option at getting this sorted out. He then goes on to describe the principle as being an object, the objective being to core out as much of the bile duct from within the liver as possible to carry out a successful anastomosis. And you can take what you want from there. So he starts off by saying one option is a direct duct-to-duct anastomosis. Hardly ever applies because you never have enough length to be able to do this safely. Option 2 is to take the short roux loop, put a tube across, that's a Y-shaped tube, so that Y-shaped tube holds open left and right biliary system, but then straight away it says that these tubes invariably slip out and fall out. He then describes a variant of that using a T-tube, a nice long T-tube, where you might be able to get some cholangiograms later on, but again describes saying that these tubes invariably fall out. And again, some of you may be familiar with this from the history books, where forget the porta hepatis, it's all a wreck there anyway. Let's take off the left lateral segment and anastomose the left hepatic duct, which is nice and dilated, to the roux loop, the so-called Longmire approach. He then goes on to describe the technique that is the object of this paper, which is to dissect out the porta hepatis, find the scarred bile duct somewhere in the hilum over there, dilate that up, and using a Desjardins type forceps, push that through the liver, through segment 4, which he describes as the anterior-most part of the left hepatic duct. A similar thing on the right side if you want to do some of the bilateral thing, and then introduce these across the anastomosis, suturing the back wall first, and then the front wall. Fusing the back wall first and then the front wall, and then leaving those tubes in place and applying suction onto the intrabiliary drains, as well as leaving drainage for the peritoneal space, because bile leak almost always does occur. One of the proposed advantages of this method is that in case this was to stricture down, you'd always be able to go back in and redilate these anastomoses that were done. Again, 4 patients, median follow-up in those 4 patients just over a year. He also goes on to describe later on as an addendum to the paper that 6 patients have since been operated after the first 4, suggesting there was probably a bit of a lag phase between peer review and eventual publication in 1964. It probably was a bit too late for probably the most famous bile duct injury patient from the UK. But if you go through that paper there, this is Sir Anthony Eden. He had his bile duct injury in the early 50s. The paper that describes the historical course in the Annals of Surgery does discuss that between the operation in 1957 and 1970 that they did consider the mucosal graft technique. There's also cholangiograms. They're not cholangiograms. These are barium cholangiograms. And it just shows that even the Leahy Clinic team that operated on Anthony Eden also used a very short rule loop. And again, it also is quite clear from the notes that in 1957 at that operation then, both the lobes were normal, and that the subsequent operation 13 years later, significant atrophy was seen in the right lobe of the liver. So that description of the procedure in 1964 would have been probably too late to prevent Anthony Eden's right-sided hepatic atrophy. What has happened since then that has changed? Lap choles have come. Lap choles have changed the face completely of the nature of the injury. We no longer have a transaction injury. We have an excision injury. The excision injury is accompanied with significant ischemia. We also have a much better understanding of the vascularity of the biliary tree, much better than what they had in the early 60s. We also have a better understanding of the huge amount of variance that exist with intrahepatic bile ducts, particularly some of the segmental ducts that are more prone to injury, particularly the right posterior duct draining segments 6 and 7, which has led to the definition of new types of injury. Again, this is an interesting paper from the 90s talking about segment 7, segment 8 duct, which I find quite difficult to understand as it is. What's also come about in the last 40 years is liver transplantation as a modality of treatment. And with liver transplantation, we're anastomosing normal ducts. And with pediatric liver transplantation, split liver transplantation, we're anastomosing tiny segmental ducts. So this is a split liver, the right lobe for the adult, the left lobe for a child. The child gets all the vessels short, a short hepatic vein. And the biliary anastomosis is a 2 millimeter bile duct that requires anastomosing. So you are able to carry out a safe mucosa to mucosa anastomosis with a very low incidence of strictures, especially in the transplant setting. So what are the current principles of specialist repair? We still use a rule loop as described by Cesar Roux almost 130 years ago. There's a bit of debate that still is there, not so much now, but reconstructing these bile ducts early versus late. The principles are essentially the same. You establish biliary and vascular anatomy, you ensure a well vascularized bile duct margin, and you carry out a long Roux-en-Y hepaticojejunostomy, making sure you get your liver biopsy just to make sure that the fibrosis is documented before the patient eventually develops secondary cirrhosis a few years later. I've used some of our own unit publications just to highlight what's happened over the last years, and then put this into perspective with the 2 papers I've described. So with the lap chole era, we've got a different form of classifying these injuries. In terms of repairing them, there are 3 essential groups: a largely historical group of patients who present late, who have late repairs; a group of patients identified on table where we have gone out and repaired these injuries at the referring hospital; and an in-between group, which is our standard approach for patients with bile duct injuries referred on day 3, day 4, day 5. Okay. This shows you the 1 in 6 patients that present with an on-table injury that is recognized by the operating surgeon. Here a high injury just below the bifurcation. Here a separate segmental 6-7 injury with an apparently intact main bile duct. This is only found after the HPB surgeon realized that there was a missing right posterior segment on this so-called apparently normal cholangiogram, and a separate rule loop to that segment 6-7 duct was carried out. There are advantages of immediate on-table repair, which are quite clear. It's a single admission. There's no need to transfer the patient somewhere else. It's better for the patient. It's all sorted in one go. There are disadvantages. You're doing an operation where the injury has not yet fully evolved. The ducts are small. You're doing this in a strange place with strange kit. We all have 5.0 PDS in our glove compartments of our cars as something we carry around as something we carry around with us. As far as the early repair, the same essential disadvantages of and the advantages of the immediate repair, except for the fact that you're doing this in the presence of a lot of inflammation. Okay? So the idea is you do this early on, within the first 3 weeks, after achieving initial control of biliary and abdominal sepsis. Again, the disadvantages: the anastomosis involves undilated ducts. There is some inflammation that's that is still present, and the extent of ischemic injury is still quite unclear. And these two pictures show you clearly the difference. That's a nice clean abdomen 3-4 months out after. This is even longer. This is 8-9 months out after a stricture with a partial atrophy of the right lobe. And this is a 2-week-old injury with a common hepatic duct injured, a right posterior duct injured, and the common hepatic and the right hepatic artery running between the two, all damaged as a consequence of bleeding experience with multiple clips that were applied at the time of injury to the right hepatic artery. Just recently had this paper accepted by the annals comparing the 3 groups, and again, it's not really comparing like with like, but it just shows that by repairing these ducts early, either on table or within the first few weeks, you're not doing this at a cost of late stricturing. So there is follow-up well in excess of 5 years now. So this has become standard practice in terms of management. Just go to the next slide, please. Okay. What's also changed compared to 1964 is litigation. Okay. Clearly, there were no issues with litigation in those days, and I've tried to again identify some of the factors that were raised in the 2 papers. So whether the repair was done by a so-called specialist, whether the first repair was successful, and looked at a paper that we've again recently published, looking at risk factors for bile duct injury. If you look over here, an on-table repair by the referring surgeon comes out as the highest risk factor for litigation. A young patient, the patient's perception of incomplete recovery after bile duct reconstruction, an associated vascular injury, and a laparoscopic cholecystectomy in the most recent era. And this is reflected by what is out there in the literature. Again, I've produced, put up three papers. One from the Dutch group that have a huge experience with Duct, again talking about the MDT, the multidisciplinary approach, having a much better outcome for managing these. From Ron Busuttil's unit in the States, talking about early repair at specialized centers having good outcomes, and from James Garden's group in Edinburgh, again talking about the minimum standard of care is immediate referral to a surgeon experienced in bile duct injury repair. So what are our current problems? We are currently juggling a different complication. We're now juggling, for example, ischemic type strictures after complex multivisceral transplantation. These are patients who have a combined graft with a liver, an intact biliary tree, and what is almost certainly some form of ischemia or denervation. This here is a reduced size multivisceral graft with a segmental liver, an intact pedicle, and the entire bowel over there. So this again just shows you that things don't stop. So to summarize, Mr. Chairman, putting that 1964 paper, the operation as described is not carried out. But a lot of what was described still holds true today. And to start off with, the prevention of injury being paramount is crucial. I take this first repair as a specialist repair, as the best repair, is something that it is gold standard practice. The use of the mucosa to mucosa approximation. The other areas that probably don't hold as much strength compared to when this was written. I think they clearly got the length of the rule loop wrong, and that's there in quite a few publications. The need for the long-standing transhepatic biliary intubation has gone because that role has been taken over completely by the development of interventional radiology. And I think a better appreciation of the anatomical variance and biliary vascularity, what we've learned from transplantation, has also helped us. But we still do have problems with patients presenting with major combined biliary and vascular injuries as well as complex intrahepatic strictures. Thank you.